Hello, everyone. I want to welcome all the fellows to the NCVH Digital Education Series. Unfortunately, we didn't get to all meet at NCVH this year, but I do hope to see you all there next year for our NCVH annual meeting in New Orleans. And I would like to thank NCVH, Dr. Walker, for hosting this digital education series. And today, what I'm going to be talking about is pulmonary embolism and deep vein thrombosis. Again, my name is Pradeep Nair. Here are my disclosures. So the question I ask for the fellows is, why do fellows need to understand venous thromboembolism? And I'm hoping that throughout this talk, I'll be able to shed some light onto the disease process so that we can all have a better understanding of VTE and why it's important for all of us to understand treatment. So we'll start with a little historical perspective. And really, VTE was described in the 7th or 6th century BC in the Vedic times of ancient India by a physician by the name of Sushruta. And what was found is that he described in his texts about a swollen and painful leg that was very difficult to treat. This was, by and large, a deep vein thrombosis. But it wasn't until the late 18th century when Morgagni looked at clot and identified it in a pulmonary artery, but he had no idea and no explanation for where it arose. So fast forward to the mid-19th century with Rudolf Virchow, who was the first to identify the source of emboli leading to a pulmonary embolus. And so what he stated is that noted was the detachment of a larger or smaller fragment from the end of the softening thrombus, which are carried along by the current of blood and driven into remote vessels. This gives rise to the very frequent process on which I have bestowed the name embolia. So we have Virchow, who then gave us the idea of where pulmonary emboluses originated. If you fast forward again, in his honor, we then understood the Virchow's triad, which is essentially how thrombosis originates. And we need to have this triad of endothelial injury, hypercoagulability, and abnormal blood flow to get thrombosis. Now, we are talking about the venous system, and we all can have dealt with arterial clot in the past, but they're vastly different. In the arterial system, you deal with high flow, high pressure systems. The vessels taper in direction of flow. And oftentimes these patients have very dramatic symptoms and present such as a stroke or heart attack or critical acute limb ischemia. The clot morphology can also vary. You can have small amounts of soft clot in these vessels, which takes time for it to grow into larger clots. But in the venous system, we have a low flow, low pressure system, and the vessels are enlarging in the direction of flow. And here we get our DVTs or pulmonary embolus. And when you see the clot in the venous system, they're often large because with the slow flow, the clots have had time to develop and form. So simplistically, what we think about with arterial thrombosis is the notion of plaque rupture, where you can get platelet binding and platelet aggregation, leading to the initiation of a clotting cascade. But what we can see in the venous side of things is that there's very low slow flow and low shear force, and the inflammatory process that occurs attracts a lot more red blood cells, and you have more red blood cells that are enmeshed in fibrin and actually fewer platelets. So here's this little diagram of clots in general. So on the left, this is in the most earliest phases of clotting is what I call white thrombus or platelet-rich thrombus in the patient that we extracted a clot from in an acute MI situation. In the middle slide, you can see what red thrombus or venous clot looks like, and you can see how dark it is. This is red blood cell rich. And on the far right, this is what happens to clot if it's left to sit in the vessel without extraction or treatment. It turns very fibrin rich. You can see the white texture of the color of the clot, and this is very firm clot, and it can be oftentimes very hard to extract. The etiology of VTE can be split into two separate entities, inherited or acquired. Inherited VTE is a hypercoagulable state with a vast majority, with I should say 12 to 18% having factor V Leiden defects. And the acquired VTE, we have patients with immobility, trauma, malignancy, renal disease, drug users, or some medications such as oral contraceptive pills, testosterone, and chemotherapy, as well as some of our traditional cardiac risk factors that can lead to VTE, obesity, black race, male, heart failure, or diabetes. So our diagnostic testing, we have very good testing for establishing VTE, including duplex ultrasound and D-dimer. They have high sensitivities, and what we can see for DVT specifically is that a negative result typically will yield no DVT. And for pulmonary embolism, of course, we have CT scanning that is very accurate in identifying pulmonary embolus. So VTE is a disease with very grave consequences. And if you look at CDC reports, it is the third leading cause of death after MI and stroke. In fact, it's the leading cause of maternal death in both the United States and the United Kingdom. We have more deaths from pulmonary embolus than breast cancer, prostate cancer, motor vehicle accidents, and HIV combined. 1 million patients are afflicted yearly. All up to 100,000 patients die annually. A fourth of these patients with pulmonary embolus will die suddenly. And there is up to a third of mortality rates at 1 month in patients with pulmonary embolus. And if you look out to 10 years, a third will have a recurrence of VT at some point in time. And we're dealing with pandemics, and I will say today that VTE is absolutely a pandemic disease. We have over 10 million cases per year of VTE diagnosed globally. Over 700,000 cases per year are noted in France, Italy, Germany, Spain, Sweden, and the United Kingdom. We have over 540,000 VTE-related deaths in Europe annually. And there's been a significant increase in China of VTE rates. So if you break it down, death from pulmonary embolus is fairly significant. One person dies every 6 minutes in the United States from pulmonary embolus, and in the world, it's 1 every 15 seconds. So diagnosing PE can be challenging at times. It's not always straightforward. If you look at autopsy reports in patients diagnosed with PE at time of autopsy, only 18% had a pre-mortem suspicion for pulmonary embolus. And these signs and symptoms can be, you can see the differential diagnosis can be quite large, but it's important for us to understand whether or not the patient has PE and to rule it out, not just for the medical legal issues. In 2017, there was a large award given to after a college student died from a PE who was sent home for a diagnosed viral illness. But medical legal issues aside, it's important to treat these patients because of the long-term sequela that they can face. If you look at pulmonary embolus, the long-term sequela is chronic thromboembolic pulmonary hypertension, and for DVT, it's post-thrombotic syndrome. For CTEPH, up to 60% have unresolved clot at 1 year. And of these patients, 4% can have CTEPH. But more importantly, these patients don't exercise normally anymore. 50% can have persistent exercise limitations. And when you look at PTS, or post-thrombotic syndrome, almost a third will develop PTS amongst patients with DVT. And it's the most frequent complication with blood clots in the leg. They can be substantially debilitating to the patients. Many patients, after 10 years, just simply stop working because of the discomfort. And you can see in these pictures what can happen to these patients. So all of these patients, barring any contraindication, will be anticoagulated. But what we need to know is that anticoagulation does not dissolve clots. It only prevents clots from worsening. Anticoagulation allows time for the body's natural clot-busting mechanism to be activated, in which case plasmin can get activated and aid in clot dissolution. But our body does a pretty horrible job in breaking down large clots, and oftentimes what is the case is there's scar tissue, or that fibrotic clot that I showed you in the previous slide accumulating within the vessels and adherent to the vessel walls. When we look at pulmonary embolus, we have several treatment algorithms. We have one treatment algorithm that we've been following with several classifications. We have a low risk, moderate risk, and high risk PE category. Now, when a patient presents with a high risk PE, it's pretty clear. They have shock. These patients need early intervention very quickly, either with systemic lysis or in the cath lab or surgical embolectomy. Then you have the other aspect of patients with low risk PE. These are patients that are totally stable, have no symptoms whatsoever, except for maybe some shortness of breath, but there's no evidence of any right ventricular strain or elevated biomarkers. These patients can be treated with anticoagulation. Now, when we look at moderate risk or submassive PE, what we need to have is right ventricular strain, as well as potential increase in biomarkers, cardiac biomarkers, or abnormal vital signs. If they have RV strain alone, without any other evidence, they are considered moderate, low risk PE patients, and sometimes can be considered for anticoagulation based upon some previous guidelines. But if they have all of the above, they're in a moderate high risk category, and these are the patients that you can definitely consider for early evaluation of treatment in the cath lab for embolectomy, thrombectomy, or even surgical embolectomy, or even consider systemic lysis. RV is a very important chamber of the heart when determining the severity of the PE. If you have an elevated RV-LV ratio greater than 0.9, this is an independent predictor of death and hemodynamic collapse. One of the issues that these guidelines do not provide us with much information on is the amount of thrombus that you see. Sometimes we can see a lot of thrombus within the pulmonary arteries, yet they have limited symptoms. But what we have seen in studies is that the larger, the higher the thrombus load, the higher the risk of mortality, which is an issue that yet has to be adjudicated in clinical trials and into our guidelines. For DVT, what we call an acute DVT is something that's been present for less than 14 days. And we can split that down into the iliofemoral, femoral-popliteal, or distal DVT segments. If it's distal DVT and the patient has no symptoms, we can simply observe them. However, if they have significant symptomology, in this case, you would anticoagulate them. Now, in the iliofemoral DVT space, what we look for is phlegmasia. And you can see a picture of someone with phlegmasia, significant indurated leg, pain, swelling. These patients, if it's present, can be evaluated for thrombectomy. Versus if they don't have it, most often the recommendation is to consider anticoagulation. Now, where it gets very tricky and challenging to decide on the optimal treatment strategies for femoral-popliteal DVTs. Most cases, and in most scenarios, anticoagulation is the only option that is offered. But if they're having impending phlegmasia, it may be considered for earlier intervention. Once that clot is there for over 2 weeks, there can be some organization in the clot, and it can be harder to retrieve or to perform lysis down the road. And of course, if any patient is contraindication to anticoagulation, one of the main indications for IVC filters would be that. Now, the ATTRACT trial is the main trial looking at deep vein thrombosis and using pharmacomechanical catheter-directed thrombolysis. And on the surface, this was a negative trial. However, when you look closely at this study, when you look at patients treated with solely anticoagulation or catheter-directed thrombolysis, those with moderate to severe PTS had reductions in severity when they were treated with with the catheter-directed thrombolysis. And the types of devices that were utilized were infusion catheters for lysis, the angiojet single-session therapy, or the trellis device, which is no longer on the market. Important to understand, especially when we deal with patients with DVT, the Volata score. And this is a scoring system from 0 to 3, looking at various parameters, and a score of 10 to 4, and 3 being the highest rating. 10 to 14 would mean that the patient has a moderate risk for post-thrombotic syndrome and greater than 15, a severe risk for post-thrombotic syndrome. These are the patients you want to consider for earlier thrombectomy and cath lab interventions. So what are our interventional options beyond anticoagulation? Well, we have catheter-directed thrombolysis, including the ecosonic catheter, as well as the McNamara catheter for just direct infusion of lytics. We have pharmacomechanical thrombectomy utilizing the angiojet device, and mechanical thrombectomy utilizing the FlowTriever, ClotTriever devices, as well as penumbra devices. So the angiojet is a rheolytic form of thrombectomy. It's a mechanical thrombectomy device that has pumps of saline that are injected through a small hypotube at the distal end of the catheter at a very high speed. And this creates a low pressure zone within the surrounding area to create a small vacuum effect and allow thrombus to be pulled in. And the fluid is, the benefit of this type of catheter is you can actually do what's called a power pulse spray, where you can infuse thrombolytic drug into the clot prior to aspiration of thrombus. And the specific device intended for DVT is the Zalante catheter, which goes through an 8 French system. The ecosonic device, right, provides acoustic pulse generation via ultrasound to ideally treat clot by breaking its fibrin matrix, allowing potentially even more organized clot to break up, allowing thrombolysis to work more effectively. The CAT8 device is used for mechanical thrombectomy and utilizes continuous suction and aspiration, which has tremendous force of aspiration. The main benefit of this device is for more acute thrombus, and you have to be extremely cautious with how much volume of blood you can be extracting from the patient during these types of procedures. There is something called the SEPT8, which is utilized during thrombectomy procedures, which can help agitate the clot to help enhance clot retrieval. And then there's the devices, including the Triever 20 and FlowTriever device for pulmonary embolism, as well as the ClotTriever device, which is a basket aimed at retrieving DVT and clot, which I have some examples I'm going to show you. So let's go to some cases. So the first case is of what I call the cardio junkie. She was a 41-year-old female who had no prior medical history except for of pregnancies, and she began an intensive exercise program, which led to a lot of weight loss. And over the course of years, she dropped her BMI substantially and was looking for a way to reduce her excess skin on the belly, and had an abdominoplasty surgery. 3 days after this surgery, she developed sudden severe shortness of breath and presented to the emergency room. Her blood pressure was really at her goal, her baseline. Her heart rate was elevated. She was significantly hypoxemic. Troponin was elevated. She had an elevated BNP. And you can see on the echo image on the short axis view, her RV was significantly dilated, and in the CT scan with a right ventricular pressure overload. And on the CT scan, she had significant bilateral thrombus. So the question is, what would you do? Would you admit her to the ICU and initiate anticoagulation? Would you place a filter in? Would you send her for catheter-directed thrombolysis? Would you send her for mechanical thrombectomy, or would you start systemic TPA? Well, in this case, we opted for mechanical thrombectomy. And her specifically, we would not use thrombolysis because she is post-surgery, and she has a submassive PE, so we opted not to treat her with anticoagulation alone. Barring any contraindication to anticoagulation, this would be our approach for treatment. And you can see in the top right corner, she had substantial clot in her right pulmonary artery branches, and on the top left, she had significant clot in the left lower pulmonary arterial branches. And we used the ClotTriever, the Triever 20 catheter to extract the clot, which you can see in the far right, the top corner of the screen, and the FlowTriever catheter to extract some adherent clot, which was great. You see pictures like this on social media, and I think it's nice to see that we're able to extract clot like this. But this is the most important slide for me on this case, is the substantial drop in her mean pulmonary artery pressure from almost 40 to 18 with almost instantaneous relief in her breathing. So the case 2 that I'll go over is a 36-year-old that I call the engineer with brain cancer. This gentleman was an engineer. He had glioblastoma of the brain diagnosed over a year ago, and had surgery for this, but he had right-sided motor deficit after his surgery and was undergoing physical therapy. While he was doing physical therapy, he injured his right leg, and as far as his cancer is concerned, it seems to have not recurred according to his last neurosurgery evaluation, but he presented after injuring his right leg with painful, swollen right leg with discoloration. He had no shortness of breath. So this is his initial picture of the leg. You can see that his blood work showed an elevated D-dimer, and he had an occlusive thrombus in the right deep femoral vein. You can see the reddening of the skin, where he had significant pain, as well as swelling in that portion of in that leg. So the question is, what would you do? Would you give him blood thinners, refer for IVC, filter placement because of his history of brain cancer, admit him to the hospital for heparin and convert him to blood thinners? If the neurosurgeon okays that, send him for thrombolysis of the DVT, or do something else. So our choice in this was to do something else. We did talk to the neurosurgeon, and he approved anticoagulation for this patient, but obviously with his history of surgery, thrombolysis was not even a question. So we utilized what you can see in the slide, the extensive thrombus in his femoral vein. We used the clot triever device, which is a basket, to essentially extract the clot, and you can see the clearance of the clot on the screen. And so this is what the clot triever device looks like, pulling down the clot in the vessel effectively. And so you can see in this slide, almost instantaneously after extracting the clot, his leg swelling went down and the color in his skin came back, and this is the type of clot that we extracted. You can see it's relatively fresh red thrombi. So the third case is the forgotten police officer. This is a 38-year-old police officer who presented a while back with shortness of breath that was going on for 1 week. He was in an altercation with a suspect and had been off duty after injuring his leg after that incident. He had an ultrasound that didn't reveal any DVT despite not having any leg swelling, but he didn't have any chest pain. He didn't have any pleuritic pain, but he went to the ER because he was always short of breath. And he did have some hypoxemia, which wasn't severe, but his vital signs were normal. EKG was normal, troponin is normal, all the biomarkers were normal, but he had an elevated D-dimer. This is what his CT scan showed, and he had a large saddle PE, and his RV on echocardiogram was totally normal. PA pressure was totally normal. So here's the question: what would you do? Would you refer him for catheter-directed thrombolysis or mechanical thrombectomy? Would you administer systemic TPA? Would you just put him in the hospital and put him on anticoagulants, or just send him home on a DOAC? And at the time, the decision by the treating physicians was to send him home, admit him to the hospital, put him on, watch him for a few days, and put him on a DOAC. And he remained stable throughout his hospital stay. But in retrospect, this is what we wish we had chosen for this patient, because what happened was years later, he did develop CTEPH. He had progressive exercise intolerance. He had to quit his job. He ended up with severe pulmonary hypertension with a PVR of 5.6 Woods units, and was therefore referred to the Pulmonary Hypertension Center for further therapy. These are not his slides, but in these types of scenarios, there are novel agents used to treat CTEPH, but it is a significant problem when patients develop it. And finally, the final case is what I call the Katrina disaster. This was a 62-year-old FEMA officer who presented for non-healing ulcers of the leg. He developed chronic swelling during the rescue operation, was diagnosed with DVTs, and he's been on Coumadin ever since. He had several infections to both legs, requiring many hospitalizations and antibiotics. He had to quit his job. At one point, they wanted to amputate his leg. This is the picture of his wound on his right leg. He had a similar wound on his left leg. He had chronic thrombus in the bilateral deep femoral vein and common femoral vein. And here's my question: what would you do next? Would you approve him for amputation, refer him for ablation of superficial venous reflux, recommend aggressive compression therapy, or refer him for venography and evaluation of central vein disease? And what we chose was both C and D in this case. because we strongly suspected he had central vein occlusion from chronic venous disease, and that's indeed what he had. You can see the large collaterals filling, and he had essentially chronic occlusive closure of his iliac veins. And we were surprised to find an IVC filter in there, but luckily it was not fully thrombosed, and we were able to pull it out with a little bit of pressure. And then we were able to open up the veins with stenting and heal his ulcer. So I'll conclude by saying that every fellow should understand VTE because you will see it often in your career, and patients will suffer greatly from it if not dealt with. And nowadays we have many options for treating these patients. And if you're ever in doubt regarding the options for treating these patients, I would say call somebody who knows, who treats this routinely earlier rather than later, because you can really have a tremendous positive impact on a patient's life. And with that, I thank you.